All right. Well, let me introduce Pearce real quick for those that may not know Pearce. Pearce is a med student over at UCSD. Has taken some time away from those studies to spend in the lab with Bahar and her team. And he has, for some lovely reason, found a interest in PJK and has been diving deep into it for probably, I would even say, the better part of a year, or you probably can tell me even more, Pierce. Maybe it's even longer than that now. But it went from doing things like just reviewing the literature and trying to figuring things out from that end to translating that over into the lab. And now we're even looking at tissue specimens that we're collecting, um, and doing some biomechanical work on that. But Pearce has been kind of a workhorse behind that effort. And um, anyways, applaud you for your efforts, Pearce. And I think he's probably as well read, if not more well read than the rest of us on PJK right now, as he's been living in that world for a little bit. So looking forward to this talk, and thanks for being here, Pearce.
So thank you, Dr. Mundis, for that introduction, and that sets this talk up very nicely. It's a good introduction to what I'll be talking about. So I titled this one, and like Dr. Mundis said, yes, I'm a medical student taking a gap year between my third and fourth years, working with Dr. Bahar Shahidi here at UCSD, and all the surgeons here are very familiar with this concept of proximal junctional kyphosis. I thought that I'd be able to bring a little bit of some of the newer perspectives and an emerging sort of subgenre of PJK risk into the field here today and introduce it to you all. But to start, I will just start with two cases to sort of illustrate the breadth and depth of this topic. And so we can have two patients, similar demographic characteristics. One of them, 60-year-old female with history of symptomatic ASD. They received a T10 to pelvis fusion. 1 year later, they present with new radicular symptoms, found out a fracture of the T10 vertebrae. Sort of same person, T10 to pelvis fusion, but at first follow-up 1 month later, is found to have PJA of 30 degrees and new associated worsening back pain. Sort of both of these things set apart by different times and with the different presenting different sequelae, still termed PJK. I figured I could throw any topic or any graphic up here because I know that a lot of the surgeons here have probably seen this in their clinical practice regularly. But it's that, situation where you'll provide a fusion to a person, and then at that proximal junction, they start to sort of lose that alignment over time, leading to further revisions until again, maybe you get to that ultimate one that does work out, and maybe it ended up being a lot longer of a construct than you expected, but and it took 3 years, but eventually they end up being all right. The definitions obviously vary with PJK, and they seem to be changing year by year, but the pathology still remains, which is the loss of alignment at that proximal junction leads to complications and a sort of a poor outcome. So when I first started with Bahar, I was a bright-eyed, bushy-tailed medical student, came to her and said, I want to do orthopedic surgery, I want to do orthopedic spine. And she said, well, have I got a lot of work for you? And is there a topic that is going to be right up your alley? And she said, there's this topic known as PJK, and there's an extensive literature base about it. And what we think has maybe been lacking in it, from the basic science side, is a look at maybe more of the some understudied topics and stuff like that. So what she said is we need to get a survey of the landscape and try and be as exhaustive as possible in that process. And at the time, there was a very well done review, a review paper that was sort of purporting to be discussing the most pressing PJK risk factors at the time, although that review had kind of overlooked a lot of, if not all, the soft tissue components that need to be looked at, in our opinion, in regards to this topic. Things like muscle, things like ligament, things like bone. And so what I did is did a systematic review with a little bit of a different criteria, which was I just looked at the literature base going back till 2010, and I collected every paper I could find that was evaluating PJK risks, and that turned out to be 150 papers. And we sort of did a characterization of that paper of that literature base, and we found that, you know, amongst the three different stages of the perioperative period, the intraoperative stage was the most commonly looked at stage when risk factors were taken into account. Meaning, you know, sure, we should look at patients' BMI and we should also look at their alignment postoperatively, but intraoperatively, that's where the meat of the topic is. And that still remains true, and that's an important thing to continue to consider. Although we are thinking that we might be missing some components in that preoperative period that may benefit us in the future. In addition, using a modified grade criteria, which is, grade criteria is usually used to evaluate the quality of like an outcome or a recommendation. But when applying it to papers, and in specific, we could see that a large majority, over 90%, were of very low or low quality based on that criteria. And that comes largely due to the fact that they're all, mostly uh, uh, retrospective analyses. So going further, when we look at what categories those risk factors fell into, we found that, an overwhelming majority, again, were mechanical based. And I'll go into a little bit more detail as to what we termed mechanical. But the important part here is that anything related to tissue and tissue-based risk factors was made up like a large majority of the literature base of risk factors, only about 5%. And then if you look at the number of times that a risk factor was found to be predictive out of the number of times that it was evaluated, those mechanical factors were essentially very seldom predictive, meaning you could look at X metric, SVA, for instance, you could look at it 1,000 times, but it would only turn out to be predictive in a relative few number of times. As opposed to when you looked at bone, ligament, muscle, disc, the number of times it was evaluated and the number of times it was predictive was very high. And so what we kind of ended up with was this heat map of sorts, which categorized things by, were they mechanical, tissue, or demographic in nature, and were they evaluated in the pre, intra, or post-operative period. And this gives you a better, example of what some of those mechanical factors were that we were assessing, which was in the mechanical preoperative setting, it was predominantly, sagittal alignment parameters. What's the global alignment, the UIV angle, hip lower extremity parameters, pelvic parameters, the stuff that we're most familiar with when we're talking about, well, how do we optimize PJK risk? And you could see that in the mechanical preoperative period, things tended to be seldom predictive out of the number of times that they were evaluated, as opposed to tissue-based factors, Hounsfield units of the vertebrae, UIV disc degeneration, paraspinal muscle cross-sectional area, etc., were very, very often found to be predictive of PJK out of the number of times that they were evaluated. And then getting into that intraoperative point, the things that we kind of deemed were at the surgeon's disposal during the operation, what instruments they choose, the UIV, the LIV, global correction, the amount that they decided they wanted to correct the patient. Those also were a little bit more predictive, instrument characteristics turning out to be about 50% of the time an important part. But again, out of the number of times it was evaluated, although few in the case of ligament augmentation, there's only a few studies out there right now, they're often showing good results. So we get this picture, and the question starts to come into focus, which is, are we being too, are we not being, or maybe there's some underrepresented and under evaluated topics here. So this framework we had kind of put together emerged, which was you have an individual who's received a spine fusion, and we've termed these 3 buckets as things that largely we need to be focusing on in the, especially in the research setting, and hopefully in the future in the clinical realm as well. These 3 buckets, if you will: the surgical factors, the approach, the instruments, the alignment. Importantly, the full skeleton alignment, including hip and lower extremity. And then patient factors that we're familiar with as well, things like BMI and sex and age. But muscle, bone, and ligament started to emerge as topics that will be important. And so Dr. Bahar Shahidi and Dr. Mundis got together, and a couple years before I even came into the picture, they had said, we need to get a database of patients together with tissue to try and elucidate more of these maybe underrepresented factors, muscle tissue, muscle and ligament predominantly. And so that was sort of that introduction that Dr. Mundis was talking about. That's where I kind of stepped in, and they said, we've got a ton of patient samples, a ton of tissue to be analyzed. We could use your help. And so I was glad to do it. And so today, for the rest of the talk, I'll kind of be diving into, muscle and our investigations of that tissue, and then ligament and our investigations into that specifically. So I just kind of took you way out, and now we're going to try and focus in a little bit more throughout the talk into a couple different spaces, the first of which being muscle. So when we look on MRI, and there's a lot of stuff in the literature now that's sort of well established, the lumbar paraspinal muscle quality, meaning fatty infiltration, cross-sectional area, et cetera, as an important component in PJK development. And our data agrees.
Pearce, you went on mute.
Thank you. Sorry. My computer does weird things when I'm presenting. It's something I got to figure out. But I think, as I was saying, our data agrees with the literature base, which is sort of saying that, in fact, paraspinal muscle quality is predictive of PJK risk. And so we kind of see that association again with our database of adult spinal deformity patients, wherein the PJK group did have a significantly lower cross-sectional area. And then we moved on and said, okay, so muscle is seeming to play a role, at least on imaging. So let's go a little bit further and try and determine what may be a component, maybe in the genetic realm, that may expose some more information as to why muscle seems to be playing such a role, other than the obvious, which is muscle's what's keeping the skeleton upright to some degree. So for these individuals, we decided to, Dr. Mundis was able to get a biopsy of paraspinal muscle tissue, and we performed qPCR, to elucidate some gene expression. And what popped out was, when we cluster genes together, what was done is we looked at 40 different genes across sort of a spectrum of genes that are known to be important in muscle function, whether that be muscle metabolism, muscle contraction, etc. And what was found on sort of this is a clustering analysis, wherein it's a statistical method by which we can sort of cluster, we can put a number of genes with their expression that we found into a program. And what the program is able to do is sort of cluster genes that sort of will naturally cluster together and give us p-values based on if they're significantly associated with a certain outcome. So at the bottom, we can see PJF being our outcome, and we can see that in cluster 5 of genes, there was a significant association with PJF. And what we do further from there is decide, okay, well, what's in cluster 5? And we can see that the genes myosin heavy chain 3, ADIPO-Q, and PDGFR alpha are associated, are sort of the genes that weight most predominantly in cluster 5, sort of the translation there being that based on our early data with gene expression of those muscles in PJF patients versus those who don't get PJF, these genes seem to pop out as being possible important components: myosin heavy chain, adipo-Q, and PDGFR-alpha. This is early and ongoing work here with the gene expression data, and we're hoping to continue to look at more targets and to see if anything comes out as a more compelling story. But for now, this is kind of what we're going off of. The next question is, so we got that ligament. We also have ligament samples from patients, and the obvious next step there is, well, we have these ligaments. Let's try and perform some biomechanical testing of these ligament biopsies and see if there's some structural components in the macro setting that are different between the groups that develop PJF or PJK and those who don't. And upon sort of loading the tissues with with increasing amounts of tension, what we see is that individuals who developed PJF had much lower maximum load. The translation here being that when a tension is applied to the ligaments, they're able to, what we're looking at here, what the readout is this is a stress strain curve wherein we can see ligaments are given more and more tension and force is applied to the ligaments until a point where they sort of no longer are able to resist that stretch, essentially. And, there's a lot of nuanced terms in this space as to what the exact definition is, but what we can see here is that, essentially the maximum amount of tension that ligaments were able to withstand before they failed was lower in the PJF group. And so then the question becomes, again, like muscle, okay, we're seeing this on a macro scale as far as the ligament biomechanics go. What if we dived a little bit further and tried to look into, what the extracellular matrix sort of looks like in the ligament tissue? And what we see is when we look at the glucosaminoglycan to collagen ratio, well, I'll just back up and say, when we look at the collagen content and the glucosaminoglycan content, we can see that there's a smaller ratio. There's a smaller ratio of GAG to collagen in those who developed PJK. The translation here being that, well, I should say that similar to how we think of discs and how we evaluate disc quality is, how much glucosaminoglycan is in the extracellular matrix of a connective tissue is sort of a proxy for how well it's able to, or it's found to associate well with how well it's able to withstand pressures, and in the ligament space, how well it's able to withstand stretch and strain and things like that. Importantly, we don't see an absolute difference between collagen content between PJK and no PJK or PJF, non-PJF. And we also don't see an absolute difference in the GAG content. But when looking at that ratio, we do see that there's sort of fewer GAGs to collagen within the tissue of those who develop PJK. So, it again begs the question, okay, so there seems to be a lower quality of the ability of the ligament to withstand stress and strain. And there's also this interesting extracellular matrix difference between the PJK patients, indicating we maybe there's maybe some more there worth investigating. So I've kind of just given you a smattering of what we've done so far, and this is a very large database of ongoing work and ongoing study. But the question then becomes, why do all this stuff? Why are we looking at the GAG content of ligament in those who develop PJK? And I kind of want to try and create an analogy here between cancer therapy and how that's gone over the years and stuff like that, which is, let's say you had 3 tumors. One is, has blue antigens, green antigens, and purple antigens. And if we apply a targeted antibody or targeted therapy to the green tumors, But we apply it to all the different tumors, we get sort of this picture that looks like 33% effectiveness, and we kind of scratch our head and go like, gosh, I thought this was the answer. But then we kind of learned and was learned in the cancer space that, well, if we identify the individuals who would be best candidates for this targeted therapy, then we get something closer to 100% effectiveness. I get this is reductive, and 100% effectiveness for cancer therapy will be a miracle, but the principle still remains. I'll then change this picture to try and look something like this, which is, let's say you have a ligament that's good, a ligament that's damaged or poor quality, and then another ligament that's good, and we apply ligament augmentation in the intraoperative setting. We get a picture that looks like 33%. Although if in some way we are able to identify those who are at risk of ligamentous failure predominantly, and we augment them, then we might get a picture that looks more like 100%. So what I say here is, we can take someone with adult spinal deformity. They've lost their lumbar lordosis. They're in need of a fusion here. The first question, I don't want it to seem as though I'm coming in here saying like, as long as if we can just change the soft tissue quality, everyone will be fine. I'm fully well aware that there's an emerging, or there's a long-standing and very well established literature base around what is the optimal alignment for patients, what are the optimal instruments. Those, as I discussed earlier, still hold weight. So, you take an individual like this and you say, okay, we need to determine their optimal alignment goals first and foremost. Excellent. But then I pose a tissue readiness evaluation or some type of tissue evaluation, which, is in the future, I hope, could then be done, which might then tell us, okay, this individual is at risk of a bony failure. Maybe we go with bone fortifying agents in the preoperative setting. Maybe they get cement augmentation of the vertebrae during the intraoperative setting. Their ligaments don't seem to be up to the task. Maybe a ligament augmentation for this individual. Their muscle quality seems to be of a certain degree poor enough where they warrant some type of prehab exercise program, something of that nature. And so I kind of deem this as like, this work has the potential to essentially usher spine surgery into the era of personalized medicine to some degree. So conclusions here being that there appears to be an under-recognized and emerging sort of risk base, adding to the already rigorously studied biomechanical risk factors for PJK development. And an enhanced knowledge of this relationship between those biomechanics and the soft tissue physiology, like I said, could bring us to an era where patients are getting more personalized and specialized care based on their physiologic presentation. Future directions are very obviously in the realm of needing to expand the opportunity for surgeons to integrate and modify these factors. I've just given you a bunch of basic science experiments, and the question may be going like, all right, what am I going to do with this? I'm fully well aware of that, and that is, hot on our tails as far as things that we're concerned about. And in regards to that, we are striving to translate these essentially biomarkers at this stage to clinically accessible tests. The most low-hanging fruit of which are more nuanced imaging techniques that in the ligament, glucosaminoGlycan realm, for instance, there are, MRI sequences that are able to pick up GAG content specifically more in a more specialized fashion that, who knows, that may be the answer to assessing ligament quality in some individuals or something like that. But those are two large future directions, and this is early work. And at the end of the day, I'm very happy to present this work to everyone, and I hope that at the very least, this allows you to go into your next conference and next sort of research endeavor thinking like, okay, soft tissue, something's going on there. We need to look at it. So thank you all for having me and allowing me to talk to you here this morning.
That was excellent, Pearce. Thank you. And
Well done.
so I have a thought. I have a couple questions. Like, so confounding variables, right? So patients with, say, poor paraspinal muscles at the planned UIV, or we'll just take, the T10 area, which is commonly studied. Like, is that not also a metric of frailty, a metric of advanced physiologic aging? you know, you know what I mean? Like, so for instance, perhaps, that patient is different than one that's well compensated and, has, muscle that's ready for a really big insult, right? Is there a confounding variable there, do you think, between PJK and the fact that that muscle is already crappy?
The simple answer is absolutely. There's a confounding factor there. If we were able to look at the paraspinals of the individuals who got the same surgery, and were the same age, the same BMI, and things like that, I should hope that that quality would still portend the same outcome. But the question remains, which is, are all these patients optimally aligned, and aligned for their age and alignment goals and such like that? So, I think we've talked about this before, but the optimal way to test all of these concepts would to be take individuals who, based on the surgeon's perspective, were optimally aligned for their, known demographic characteristics, age, etc., and alignment, and then evaluate their soft tissue and see if that either still plays, or no longer plays, or plays a larger role at that level. Yeah, I don't know if I answered your question very well, but I will say that I often tell Bahar that this field is so encompassing. It just feels like there one day will be a theory of everything that will pop out, that will just be like, that's it. These are the 20 things. If we just dial them in all right, this is the equation, right?
It's
That's
incredibly complicated, isn't it, Pearce?
Mhm.
We're doing through the SRS, we have an adult deformity task force that is working through a lot of this. And to Greg's point, I think there's the complicating factor is that these issues that you're studying are in part related to senescence and frailty, but there's also a genetic predisposition that we don't fully understand at its spectrum, like both ligament and muscle, bone, all of those variables that lead to a PJK or PJF risk have weighting and onset and underlying risk provision that is extremely difficult to weight, and it takes huge patient population to study it and tease out in that multivariate manner how much they play a role. But I think even with what we're studying in this realm, there's a younger group of patients that suffer from hypermobility, like Rich Santori talked about in orthopedics, that affect spine patients pretty profoundly, and we don't understand that. Trying to figure out how it affects not just deformity patients, but all of our patients, I think will be meaningful, and hopefully these little iterative steps that you're taking will give us better ways of treating it.
Hey, Pearce, that was great, Stephen. I'm just wondering, what of these risk factors are modifiable, right? Like you mentioned, their muscle quality. You look at the MRI; it's all fatty infiltrated. And you mentioned getting them into prehab. I don't know if are there any studies that look at people that came in with an MRI that has a bunch of fatty infiltration, then they go do a bunch of prehab and they come back, get another MRI, and is there any improvement, or is that muscle just is it done?
That's a very excellent question, and sort of this these slides are sort of, in doing this work, we kind of advocate for improving the quality of some of these studies, which is, like I said, this very low paper quality is predominantly based on the fact that there are retrospective studies. And so in doing this work and writing this manuscript, of which these figures belong to, we sort of advocate for taking the time to perform a better quality study evaluating prehab muscle and stuff like that, of which is being done at, is being pursued at various institutions and stuff like that. I'm aware of.
Yeah, I think Virginie Lafage and her group are actually looking into that right now. I think they have a group that's doing that.
I think that there is some support for being able to reverse fatty infiltration with a certain level of dosing, and it doesn't matter where you start from in terms of how much fatty infiltration you have, but there are other specific features that will predict whether you will be a responder, and those things haven't been totally sorted out yet. So some people respond and some people don't respond, and it doesn't matter where you start from, but it's a little bit unclear what the responder base is going to be.
Yeah, Bert Mooney, who's the former NAS president, was a San Diego native. He looked at paraspinal fatty infiltration in the lumbar spine and found that with PT, you actually do change the muscle. So that was one of his, I think, landmark articles when he was still with us. But we don't. I don't know if we have the same data for the thoracic levels. But I think that all, because there's a lot of these studies that show the change in sagittal alignment. So let's say your ideal L1PA and T4PA are, and your ideal C2 tilt and all that stuff. And let's say you hit it perfectly. Well, the PJK rate doesn't go down to 0. The other thing we know is that if you have a large change in your alignment, that's a risk for PJK. And it may be that the reason why patients that are aligned, in quotations, ideally, why they may still fail is that massive change may be more than the ligament quality can right? Like if the glycosaminoglycans are off, or if the cartilage is off, that may be, that may be problematic. So I think you're right. I think this will end up having a very personalized approach where you have a ligament marker, you'll probably have a muscle quality marker, you'll probably have a bony marker, and it may be that patients with terrible muscle just need longer fusions, right? We may figure that out, or not have surgery at all, something like that. So, yeah.
Bahar, you had some data from Comreza's group.
Yeah, that was kind of what I was referring to. We've done quite a bit of work in looking at how much you can get hypertrophy and reduction of fatty infiltration with specifically machine-based resistance exercise dosing. And we do see that there's a reduction in fatty infiltration and an increase in muscle hypertrophy. This, as Greg was mentioning, is, we've primarily been looking at the lumbar spine in this case, and Pearce and I are actually looking at prehab, clinical trial with prehab in the thoracic spine. But it's a little bit more tricky to look at that area, although some of the prior kyphosis literature suggests that you do get some, if you are applying thoracic resistance extension exercises, you get improvement in alignment. So in certain adolescent kyphotic conditions to a certain extent, and then that's probably one of the more successful areas of conservative management and deformity literature, but in the younger cohorts. So that's kind of where we're trying to apply our newest types of treatment. But I think the issue is prehab versus conservative management preoperatively is a very different thing. Conservative management preoperatively is targeted towards the pain generator typically. So the PTs are focusing on most of the time the lumbar spine, and they're not focusing on the lumbar spine, or on the thoracic spine, I mean. And so I think if you're thinking about prehab targeting the projected UIV, it's a different focus, and that is something that we're trying to sort out at the moment.
Interesting.
Was there a time dependence with that, Bahar? You needed at least 3 months for the dosing of it to see certain types of changes, 3 times a week versus 2 times a week?
Not so much timing in terms of frequency, more so dosing in terms of intensity. Like you got to get to like 60 to 80% of a max. And actually, surprisingly, a lot of people can tolerate it. I think that the concern with many programs is that you're going to flare somebody up, but particularly in the context of prehab, where somebody knows that they're going to get surgery, you'd be surprised what people are willing to do and tolerate, because they feel like they don't have that same threat of like, oh, I'm going to make something worse, and then I'm just going to have to live with it, and there's nothing to be done about that later. They're less afraid to do things when they know surgery is coming.